Walk into any clinical research department and you will hear the same question. Which statistical test should I use? It is an analytical dead end. The correct first question is different. Before you build a table or run a single p-value, you have to ask, what type of data do I have? If you do not understand your variables, accurate analysis is mathematically impossible. A variable is the single foundational building block of your dataset. It is any characteristic, measurement, or event that can differ across your study. This includes physical traits like BMI, events like mortality or readmission, and metrics like length of stay. If it can change from patient to patient, it is a variable. Every variable has a dual nature. You must define two properties for every column, its study role and its data type. The critical sequence is defining the role first. The exact same data point serves different functions depending on your question. Failing to architect these two aspects up front is why statistical plans collapse. You must define the data before calculating it. A variable's role is not a fixed law of nature. It is dictated entirely by your research question. This diagram maps out those relational roles. At the center is the outcome variable. This is the primary result your study aims to explain, predict, or compare, whether that is mortality, readmission rates, or a change in HbA1c. Driving that outcome are your exposures and interventions. An exposure is a factor associated with the result, like obesity or a history of smoking. An intervention is an active treatment or program given to a specific group. Below that sits the comparator variable. This establishes your reference baseline. It represents the group receiving a placebo, standard care, or no exposure at all. Then we introduce complexity. A confounder is a variable related to both the exposure and the outcome, creating a distortion. For instance, in a study tracking hypoglycemia and inpatient falls, age is a major confounder. Older patients are inherently more likely to experience both low blood sugar and physical falls. You may also track predictors, which estimate future outcomes, and covariates, a broader term for secondary variables included in your statistical model. Until you have mapped these specific relationships, feeding data into a program is nothing more than sophisticated guessing. Once the study roles are locked, we pivot to the data type. This statistical nature dictates how a variable is summarized, what graph suits it, and ultimately which test you apply. Look at this taxonomy. At the highest level, every variable splits into one of two branches, categorical or numerical. Under the categorical branch, we find binary variables. These possess exactly two options, like mortality or smoking status. The absolute rule here is explicit coding. Writing down 1 means nothing unless you formally define that 0 equals no diabetes and 1 equals diabetes. Next are nominal variables. These are categories with no natural hierarchy, like blood group or hospital department. Even if you assign numeric codes, they do not possess mathematical value. A 2 for surgery and a 1 for medicine does not mean surgery is twice as high as medicine. Rounding out categories are ordinal variables. These have a clear order, like disease stages or pain scales. But crucially, the mathematical distance between mild and moderate pain is not necessarily equal to the distance between moderate and severe. Panning over to the numerical branch, we find continuous variables. These capture values across a fluid, granular range. Think of age, blood pressure, or a highly precise BMI measurement. Finally, we have discrete numerical variables. These are exact, indivisible counts, the number of clinic visits or the number of complications. They are numbers, but they often require distinct statistical handling compared to continuous data. If you mislabel a variable's type here, you will inevitably execute the wrong mathematical operation later. Standard variables are static, but adding time or unstructured text adds a volatile new dimension to your entire dataset. Date variables, like admission or discharge dates, are required to calculate vital metrics, including total follow-up duration or length of stay. This becomes critical for time-to-event variables. This timeline records the occurrence of an event, such as a relapse, alongside the exact duration until it happened. Notice these lines ending early. Some patients leave the study without experiencing the event. They are censored and require specialized survival analysis. Time also creates repeated measurements. A single patient might have multiple blood pressure readings. Treating these lines as if they represent completely independent, separate patients is a massive analytical failure. You must also account for derived variables. These are metrics generated mathematically from other columns, like calculating a BMI directly from raw weight and height inputs. The strict rule here is that all derived variables and their specific thresholds must be defined precisely before you even touch the analysis software. Finally, free text variables, physician notes, and discharge summaries hold massive clinical value but are mathematically useless until processed. They demand rigorous manual coding or natural language processing to extract valid data. Complex variables allow you to analyze messy clinical realities, but they only function when governed by rigid, predefined rules. All of these rules, types, and rules must be documented in one central location. The data dictionary is the mandatory master blueprint and the ultimate source of truth for your research. To lock down a variable, this grid requires essential columns: the variable name, its label, role, data type, clinical definition, coding, unit of measurement, source, timing, and how missing values are handled. Let's walk through a specific example. For hypoglycemia, we establish the basic architecture. The name is hypoglycemia, its role is our exposure, and its type is binary. Next, we set the clinical boundary. The definition is any documented glucose below the chosen threshold during admission. The coding is strictly set. 0 equals no, 1 equals yes. Finally, the logistical parameters. The source is pulled from laboratory records, and the timing is specifically bracketed to occur during admission but prior to the outcome. This document establishes the technical protocol for the team, aligning the researcher, supervisor, and statistician on the specific meaning of every data cell. Without a completed data dictionary, your dataset is a black box. If it is missing, the research is scientifically invalid before the analysis even begins. When data types are explicitly locked down, the correct statistical test becomes a logical consequence of the study design. Look at this matrix mapping. A binary outcome, readmission yes or no, drives you toward logistic regression. A continuous outcome points to linear regression. A time-to-event outcome steers to Cox regression, and count data leads to Poisson models. The path is clear, but early career researchers routinely derail their studies through a few specific architectural failures. Common mistakes include treating categories as continuous numbers, failing to define 0 and 1, mixing units, and relying on vague variables like patient improved. But the ultimate process error is exporting a massive spreadsheet of raw, unmapped data and sending it to a statistician without a data dictionary. The test calculation is merely a mechanical output. The true intellectual work is building the data architecture. Modern research now utilizes artificial intelligence at this architectural stage. AI is highly effective here, but only when constrained by strict safety parameters. General AI and source-grounded tools can rapidly accelerate the drafting process, pulling definitions directly from your uploaded clinical protocols and generating initial variable lists. To properly identify variables, use this prompt. Act as a clinical research mentor. My research question is, insert question. Identify the outcome, exposure, comparator, confounders, predictors, and covariates. For each variable, suggest the likely data type and explain why. To draft your master blueprint, prompt the AI to build a data dictionary, including name, role, definition, coding, and source. Crucially, explicitly command the system, do not invent clinical thresholds. This highlights the absolute limitation of AI assistants. They must never be allowed to invent a clinical cutoff, and they cannot autonomously decide final statistical methodologies without evidence. Furthermore, you must never upload identifiable patient data to public AI platforms. It is a severe breach of research ethics. AI accelerates the mechanical drafting phase, but the human researcher retains absolute liability for verifying every clinical definition against established institutional guidelines. The core methodology is straightforward. Move past the search for a statistical test and begin by defining the data architecture. Remember the core principles. Variables are the building blocks of your dataset. A variable's role is dictated by the study. Its data type dictates the mathematics, and predefined explicit coding is non-negotiable. Your completed data dictionary is the shield that protects the integrity of your entire study. Strong statistical analysis can only ever be built on a foundation of rigidly defined variables. For more deep dives into clinical research methodology and data architecture, subscribe to Bayyinah Health Research Advisory. Ensure your research is built on evidence, right from the very first variable.